So biology has been doing its thing for about 4.5 billion years, and our next speaker is going to tell us about what's going to happen next, how the whole game's going to change. He's a surgeon, he's a researcher, and he's the director of the Wake Forest Institute for Regenerative Medicine, Dr. Anthony Atala.
It's great to be with you today. One of the things I'd like to talk to you about is regenerative medicine. I actually need the clicker, though. Thank you. This is a field, actually, called regenerative medicine that has to do with creating tissues and organs. If we look back at our history, it's interesting to see what our history shows. This is actually a painting that hangs at the Conway Library at Harvard Medical School, and it shows the very first time an organ was transplanted. You see in the back room, you see the surgeon getting the patient retrieving the organ, and in the front you see Joe and Mary getting the patient ready for the transplant. The first organ was actually a kidney. That was back in 1954. So many lives have been saved by this one simple procedure, which was very complex to get to, of course, but now is quite simple as we do it. But still, many lives that need to be saved. Patients are dying every day because they don't have enough organs or because they're rejecting the ones they're getting. In fact, the statistics are fairly stunning. Every 30 seconds, a patient dies from diseases that could be treated with tissue replacement. So wouldn't it be great if we could regenerate ourselves? What if actually we had an injury and all of a sudden our organ would regrow? Is that science fiction? Not really. In the biology, there are many examples of how this happens all the time. This is actually a salamander. This is real time-lapse photography of an injured limb in a salamander, and you're seeing it regrow within a 2-week period. And as humans, we're regenerating all the time. Your skin is turning over, for example, every 2 weeks. The lining of your intestine is turning over every 7 days. So your tissues are constantly regenerating. So this field that we call regenerative medicine really brings together many different technologies that will help you regenerate. We can do that with scaffolds alone. Scaffolds, which are just like a piece of your shirt or your blouse. They're like materials that we use to repair tissues. For example, this is a machine that we use. It's like a cotton candy machine, and it's spitting out this fiber, but this is a very specialized fiber, and it's creating this tubular structure around this mandrel. And we can then take that tubular structure out, and this is made out of this material that once inside your body, it will disintegrate. It's designed to just last a few months. We can then use some of these materials, and many, many different scientists working on many different materials to actually replace tissues. This is, for example, a patient who presented to us with an injured organ. And you can clearly see the area of the defect on the top. So what we ended up doing was the top area was scar. So we removed the scar and we replaced that top area only with this material that we created in the laboratory. This actually shows you how this works. We preserve the bottom portion. We remove the scar and replace the scar on the top with this biological scaffold, if you will. And by doing so, the cells from the base start to walk on that bridge and bridge the gap. And then a few months later, the organ is fully regenerated. You can see here on the left the deceased organ. You see the material that we used in the center. On the right, you see the fully regenerated tissue. And a few months later, that material is totally gone, completely replaced by the patient's own cells. And that's how regeneration works. Unfortunately, it only works for small distances, about ½ centimeter from any normal edge. So for other types of structures, longer structures, we actually do need cells. For example, we can use cells alone or cells with the materials. To use cells alone, for example, we can take small samples of tissue from the patient. Let's say a patient has a burn. Your skin is made up of different tissue layers. And the deeper the burn, the more serious it is. And a lot of patients die from burns because they don't have enough coverage. So the strategy here, this was developed by Fiona Wood in Australia, And now we're doing clinical trials here in the U.S. and coming out of Wake Forest. We basically take a very small skin biopsy, a very small piece of tissue from the skin from the patient in the operating room. In the operating room, the cells are scraped away. We grow and expand the cells right there in the operating room. The cells are actually placed in a spray gun and sprayed right on the patient at the same time to cure the burn. And this is actually having very good results in about 10 centers right now here in the U.S. And then we can use cells and scaffolds for things which are more, that have more girth or larger structures in the body. The way this works is we use the very same materials that I showed in the beginning, and we then use cells from the patient to create these structures. So the patient comes in to us 6 to 8 weeks prior to the scheduled surgery. We take a very small piece of tissue, less than half the size of a postage stamp. We then tease the cells apart from the tissue. We grow and expand the cells outside the body. 4 to 6 weeks later, we have enough cells for our construct. We then create the construct in a period of 2 weeks and place it back into the patient. This actually shows muscle strips that we've engineered. You can see these strips, and we're exercising them so they know what to do once we implant them. So basically, we take a scaffold like the one I showed you at the start, and we coat that scaffold with the muscle cells, and we then create these muscle strips as you see here. And these are flat structures like skin, which are the simplest to create. Tubular structures, slightly more complex. Tubular structures usually have 2 cell types, and it's a tubular configuration instead of a flat structure, so it's more complex. And this actually shows an organ that was replaced using these techniques. This is actually the urethra, the channel that connects the bladder to the outside of the body. And you can see here this patient had a major accident in a car, and the whole midsection of the urethra was totally gone. So what we ended up doing is we took a very small piece of tissue from the normal side of the patient, we expanded the cells, took that material I showed you at the start, we tubularized the material. It's made up of 2 different cell types, so we coated the outside with the muscle cells, very much like baking a layer cake. We then coat the inside with the other cell types. We then take this tubular structure, place it in this oven-like device for about 2 weeks, let it cook, if you will, under the same conditions as the human body. We then take it out and plug it right back in. And you can see here on the right the fully regenerated urethra in this patient. We actually published this early this year showing a series of patients who are now over 7 years out from having these organs created. Other tubular structures we're working on include blood vessels. This is actually an engineered blood vessel in the laboratory. We actually exercise these as well before they get implanted. Same strategy. We take the tubular structure, but now we're going to use different cell types. We use muscle cells on the outside and blood vessel lining cells on the inside. And on the right, you see an X-ray of a carotid artery. That's the artery that goes from your neck to your brain, to show you experimentally how we can replace those at this time. More complex tubular structures include heart valves. This is an engineered heart valve you're seeing here. Again, same strategy. We coat this with cells, and then we exercise the heart valve so it knows what to do before it's implanted. You can see here the heart valve leaflets opening and closing. And this is actually still experimental, where we're getting ready to put this in patients. This is actually a technology that has already been in patients, which is a bladder. Now, we talked about flat structures being the simplest, tubular structures being more complex. Hollow, non-tubular organs are one higher level of complexity because the functionality of these organs are definitely higher than the other structures as a rule. And the cells are usually also more complex. But same strategy. We go to the patient 6 to 8 weeks prior to their scheduled surgery. So we bring these patients in who have end-stage disease, take a very small piece of their tissue, less than half the size of a postage stamp. We then tease the cells apart. We grow and expand the cells outside the body in large quantities. It takes about 4 weeks for us to do so. After the 4 weeks, we then take a scaffold shaped like the organ, and we then coat the inside with these lining cells, the outside with the muscle cells. We place it in the oven-like device. 2 weeks later, we take it out and plug it right back in to the patient. We did that experimentally back in the 1990s and also in the late 1990s when we started implanting these in patients, and we are now several years out from this experience. On the right, you can see the actual mold, the scaffold, if you will, as it's being seated or coated with the cells. Now, solid organs are by far the most complex. This is an ear mold that we are seating with cartilage cells. And solid structures are more complex because of the poor vascularity that is there if you don't provide it. This is actually a digit that we're engineering. We're putting the bone cells in the center. We're going to then place the cartilage cells in the middle portions, and we're going to use those muscle strips that I showed you at the start to build the finger from the ground up. This is still experimental, of course, but to show you how these technologies work. Now, there are more complex solid organs like the liver, the kidney, the heart. For this, what we do is we take donor organs that are not being used, that are being discarded. I don't know if you know this, but many organs actually get discarded because they can't be used. So what we do, instead of discarding them, we take them and we then use very mild detergents to take the cells away from the organ. And then we're left with this scaffold, this skeleton of the organ, if you will, that has all the elements within it except for the cells, and therefore it will not reject. But then we're able to preserve that blood vessel tree that is so critical for the creation of these solid organs. And that's what you're seeing here. You're seeing this liver tissue that has been washed. We put it in a washing machine type of device, wash the cells away with detergents. We're left just with the skeleton, and this shows you the contrast, the dye, as it's going inside this skeleton, showing you that the blood vessel tree is still preserved. We then infiltrate the meat or the parenchyma or the skeleton itself with the liver cells. We then perfuse that blood vessel tree with the blood vessel cells, and we then are able to create these miniature liver organs made out of human cells which are able to function. They show the production of things that the liver usually does, and we just published that earlier this year as well. Now, we also have different strategies for solid organs. This is a different strategy. We're using this desktop inkjet printer. That was an inkjet cartridge you saw, but instead of using ink, we use cells. And this is your typical desktop printer that's printing the structure one layer at a time. This is a 2-chamber heart that was printed, and about 4 to 6 hours later, you actually see that it starts to beat. These are the heart cells within that structure that are actually beating. And this is still, of course, experimental as well. We're actually designing more sophisticated printers now. For example, this is a technology where we take the regular X-ray from a patient, like a CT scan, and we then use computerized morphometric imaging analysis that allows us to drill down layer by layer through that X-ray at the patient's own organs. And by doing so, we're then able to target the specific organ from the patient and design an organ that will fit within that specific cavity. We then take that information, we transfer that information to a CAD printer and to a CAD unit. Once we have all that software, through that software, we then start to seat the cells. And this is a later generation printer that can print down to a nano level, very, very small areas of tissue, one layer at a time. That's how we're printing miniature kidney structures that we showed you there, a prototype. This is actually a miniature kidney that was engineered using a similar strategy, not exactly using the printing technology, but showing you these miniature kidneys that, when once implanted experimentally, they are actually able to function and produce urine, as you see here on the far left. That's still experimental as well. So basically, to summarize then, when we talk about regenerative medicine, we're talking about this really wide area of specialties that come together to create either tissues or cells. And basically, we go through this standard approach where flat structures are the easiest, tubular structures are the more complex, hollow non-tubular are even more complex, and solid organs are by far the most complex. And at this point at our institute, we're working on over 30 different types of tissues and organs, and 6 of these, or about 20% of them, are already in patients today in some sort of a clinical experience. Now, I always like to show this cartoon. This is how to stop runaway stage. On the top You see the stagecoach driver, he goes A, B, C, D, E, finally stops the runaway stage, and those are usually the basic scientists. And on the bottom, those are usually the surgeons. And I'm a surgeon, like I was introduced. But in fact, when it comes to research, I really do believe that method A, of course, is the right way to go. And what I mean by that is everything we do in this field, everything we've done in a very methodical manner, where we do everything we can in the laboratory before we ever think of putting to the patient. And we want to make sure that it works every single time so we can reproduce the data time and time again. And before we ever put these tissues into patients, we ask ourselves a very important question, which is, are you willing to put this in your very own loved one? Are you willing to place this in your very own child, your spouse, your parent? And if we can't answer that affirmatively, we won't do it. We will only move forward if we feel like we can do this in our own family members. And when we do so slowly, carefully, and with a long-term follow-up, where we do a series of patients with over a 5-year follow-up before we actually go to the next stage. And we follow that strategy for all the tissues we've implanted. We're very fortunate to have a really great team of scientists, over 300 scientists at our institute, all working together to bring these technologies from the bench to the bedside. At this time, I also like to acknowledge some of the funding sources which have made this work possible. And finally, I'll leave you with a short video clip of a patient. This is about a 30-second clip when he was interviewed earlier this year.
I was really sick. I could barely get out of bed. I was missing school. It was just pretty much miserable. I couldn't, go out and play, basketball at recess without feeling like I was going to pass out when I got back inside. I felt so sick. I was facing basically a lifetime of dialysis, and I don't even like to think about what my life would be like if I was on that. So after the surgery, life got a lot better for me. I was able to do more things. I was able to wrestle in high school. I became the captain of the team, and that was great. I was able to be, the normal kid with my friends, and because they use my own cells to, build this bladder, it's going to be with me. I got it for life, so I'm all set.
That's Lucas Masella. He's now 10 years out from having his engineered organ. I had the pleasure of seeing him earlier this year after 10 years. You see, when we talk about regenerative medicine, we still have many challenges ahead. We still have a lot of regulatory issues, cost issues to deal with. How do we expand these technologies to more patients? But at the end of the day, one thing is certain. The promise of regenerative medicine is all about making our patients better. Thank you for your attention today.
Anthony, this is incredible work with engineering livers and kidneys and bladders and so on. I've been following your work for a long time, and I know the bladder implantation was over 10 years ago in Luke. So how come this isn't everywhere? How come we can't all get implantations of engineered organs?
It's like all technologies. When the development of a technology through a regulatory process, the average time, just for a drug, for example, if you take your typical drug, the average time for a drug to go from phase 1 clinical trial to actual completion of phase 3 clinical trials, which is what allows you to use it for all patients, just for a drug, the average time is 14 years. So we're really looking at very long timelines to make sure these tissues are safe before they go into large numbers of patients.
What's your best estimate?
Well, I think it's, we're starting to see more tissues. I mentioned that we have 6 in patients right now. We have all the first 3 types, flat structures, tubular, and hollow non-tubular organs. We have all 3 types in patients right now. Solid organs are still, not there yet. We still have challenges to achieve solid organ. That's going to be still a number of years to try in patients. But our goal really is to expand the number of tissues that we put into patients and to also increase the number of patients that could benefit from these technologies.
Thank you so much. Anthony Atala.